How's it going, guys? We have a medium difficulty question, Gastro, steps 1, 2. For step 2, you got to fucking know this diagnosis, all right? So, 40-year-old man, he's got a 4-month history, gradually increasing fatigue, sore hands, REQ discomfort, drinks socially, does not smoke, physical exam, liver edges palpable beneath the costal margin, hyperpigmentation of the forearms, fasting glucose 130 HB 72 to 99 milligrams per deciliter, 100 to 125 is fasting, impaired glucose 126 greater, 2 separate occasions. That's diabetes mellitus. Any one random glucose 200 or greater is diabetes mellitus. HbA1c 6.5 or greater, diabetes mellitus. So this dude, diabetes, if he's had 2 of these measurements above 126. What's most likely to see in this patient? Choice A, brown pigment deposition, hepatocytes, confirmed by Prussian blue. Correct answer. Prussian blue stains iron. It's very buzzy for hemochromatosis here. Bronze diabetes is the colloquial description of this vignette. You've been following my content. You know I've made lots of clips on this. Very easy, very buzzy. So let's just walk through some of these findings. You got to know that iron can deposit in the tail of the pancreas. Okay, you get diabetes that way. Hemosiderin deposition. That's why you have hyperpigmentation. Hepatomegaly, just iron deposition in the liver, can lead to increased hepatocellular carcinoma risk as well. They can give you the same question here. Say, what's this patient at risk for developing? You eliminate the answers, and hepatocellular carcinoma can be correct. You say, what's going on with the sore hands? You can get pseudo gout. Holy shit. Okay, calcium pyrophosphate deposition disease. So it's going to present 2 ways in USMLE. Either one, they'll say monoarthritis of a large joint, such as the knee. They can say that there is an OA, osteoarthritis-like presentation of the hands with DIP involvement. They can say chondrocalcinosis in patients who have either primary hyperparathyroidism, hereditary hemochromatosis, or hypothyroidism. That's like medicine 301 level stuff, okay? But that's what's going on here. You got pseudo gout, and let's just whip through the other. And it's autosomal recessive chromosome 6 HFE gene. So let's just whip through some of the final ones here. Hepatocyte necrosis, copper accumulation, periportal hepatocytes, wrong fucking answer. Clearly would refer to Wilson disease. Wilson disease, not just the Kaiser-Fleischer rings, copper deposition, disseminate membrane in the cornea. You're going to have increased urinary copper, decreased serum ceruloplasmin. The defect in Wilson disease is decreased ability to excrete/secrete copper into bile. So that's why you get more in the urine instead. You can deposit in the liver, as we have here. Parkinsonism in a young patient is Wilson disease till proven otherwise. It's called a Parkinson plus disorder, meaning it looks like Parkinson's disease, but it's not. So progressive supranuclear palsy, axial dystonia Parkinsonism, it's a Parkinson plus disorder. Lewy body dementia, okay, so visual hallucinations Parkinsonism, it's a Parkinson plus disorder. Wrong fucking answer. And it's autosomal recessive. Choice C, intracytoplasmic PS positive. Diastase-resistant globules, periportal hepatocytes, very verbose answer choice, wrong fucking answer. This refers to alpha-1 antitrypsin deficiency. USMLE is not going to write this descriptor, don't worry. That's why it's fucking wrong. Okay, so if you don't know an answer, don't choose weird sounding shit. Not to say any of these don't, all these don't sound weird to some extent, but they want you to know alpha-1 antitrypsin ZZ allele is the worst. It's codominant. It's produced in the liver. It's an antiprotease. They can give you easy vignette of alpha-1 antitrypsin deficiency, and the answer is deficiency of antiprotease. So you can get early onset cirrhosis, you get early onset pan-acinar emphysema. So you get increased elastase activity in the lungs if you have deficiency of alpha-1 antitrypsin. Despite the name, to get increased elastase activity. So the misconception, I'd say one of the highest yield points, is that patients can absolutely be smokers or drinkers. It's just accelerated cirrhosis and emphysema that you get in the condition. Wrong fucking answer. Choice D, perivenular hepatocyte ballooning, Mallory-Hyland, wrong fucking answer. Alcoholic cirrhosis. Mallory-Hyland shows up on one of the NBME questions for alcoholism. They literally will just give you like a one-liner. They'll be like, dude's an alcoholic, what are you going to see in the liver? And the answer is Mallory-Hyland. Students are like, what the fuck? I'm like, yeah, I agree with you. It's weird, but it's something you got to know. Wrong fucking answer. Choice C, steatosis, focal inflammation, hepatocyte necrosis, wrong fucking answer. It's NASH. So non-alcoholic steatohepatitis. Apparently it's been renamed as metabolic associated steatohepatitis. It's a diagnosis of exclusion you'll eliminate to get there, meaning they'll give you a patient who's fat. Okay, so metabolic syndrome. It's assumed that overweight people have some degree of fatty liver. So the key point for USMLE is they can give you normal labs. They'll give you some dude who's overweight, high cholesterol, high blood pressure, diabetes, and they'll give you like all the labs, including ALT and AST, and they're all normal. The answer is NASH, and you've eliminated the other answer choices to get there. Occasionally, you can get slightly elevated transaminases, like ever so slightly. NASH, wrong fucking answer. You know the deal. Until you make more content like this, subscribe and tune. Appreciate your time. That's it.